Before I start, I would really like to thank the organizer of the meeting to invite me to make one of the few, if not the single, presentation from the perspective of the laboratory. So I'm very honored to represent ASLM today. So I realize that I'm not in my usual crowd of technology-obsessed laboratory people, so I decided to make that presentation on improving access to and utilization of viral load for better patient management, to be not very technical, but really highlight how the best diagnostic technology, even though really can respond to the needs, can fail to fulfill its promises in certain conditions, and what should we do not to let this happen. So the targets on the way to controlling the HIV epidemic, we have been working based on targets that have been articulated by WHO or UNAIDS. We had many years ago the 3x5, and now we are in the 90-90-90 by 2020, which have been upgraded to the 95-95-95 by 2030. And I think in the near future, we'll talk about HIV elimination. But right now, today, we are going to talk about the third 90 and how viral load can contribute to that. So is viral load testing the magic bullet to hit the third 90? And the third 90 means that 90% of the patients that are receiving antiretroviral therapy should be virologically suppressed. So we know there are many data that have been accumulated that say that viral load is more reliable than CD4 count to quickly identify virological failure. It serves as a treatment adherence monitoring tool, and it can inform appropriate switch to second line once you know about the treatment adherence of your patient. So in evidence, it might be, in theory, it could improve the viral suppression of all those patients under therapy and then facilitate the achievement of the third 90. And a few years ago, in 2013, the WHO released a consolidated guidance for antiretroviral therapy, and that viral load should be the preferred tool to monitor response to the treatment. But what is the impact on patient outcome on the third 90 now that a lot of countries are scaling up their program for viral load testing? So I wanted to share with you, and I'm sorry that the title doesn't appear very clearly. I wanted to show you what happens in PEPFAR-supported countries that are scaling up viral load with funding from PEPFAR. And this is a paper that has been published in 2016 that shows a few selected countries and describe the gaps between the testing targets of this country and their actual need. And we can see that in some countries like Kenya, Namibia, and South Africa, they actually have enough testing capacity in order to meet their target. But when we look at whether or not this gap or this lack of gap actually translate with the percentage of patients that receive at least one viral load test per year, we see that some countries are doing well, like South Africa, but in Côte d'Ivoire, for example, we are really a long way from the third 90, as only 11% of the patients receiving treatment receive a viral load test. So I also wanted to show you how it can look like at the clinic level, and I wanted to share some data that are still being analyzed from the PACER study, and I think many of you have heard of this Pan-African study to evaluate resistance that has been led by Professor Rinke de Wit in Amsterdam. And we have done a retrospective analysis in 13 clinics across 6 countries that have been participating in this cohort study. And in those 13 countries, there was a different level of access to viral load. So some of the clinics had a full access, some of the clinics had an access phasing in along the years, and others had no access at all. And we wanted to compare what were the switch practices in those clinics. And of the 20 patients with more than 2 viral load results between 2008 and 2015 of follow-up, we had 266 confirmed viral load failure based on the study viral load. And what we could see is that The proportion of patients that switch to a second line, a necessary switch, was not very different in the clinics that had full access or no access to viral load. So basically, it's really like the viral load result doesn't count at all when you take the decision to switch from first to the second line. What is the reality of viral load testing for patients receiving antiretroviral therapy? I took the liberty to borrow some data from a young Cameroonian scientist, another laboratory freak also coming to the meeting. And he has analyzed data from 830 patients that attend the clinics in the western part of Cameroon. And he has tried to understand when was the delay for those patients to receive their first viral load. And the results are really very dramatic when you see that 75% of those patients, after more than 2 years in treatment, never receive a first viral load result. And it's even more dramatic when we understand that in all those clinics, there is on-site availability of viral load testing. So please see the poster of this young scientist. That's poster number 220. So actually, these data illustrate how difficult it is for the viral load testing to actually impact the clinical outcome. And it illustrates the fact that this viral load testing is a complex cascade of care that starts with the patient visiting the facility, the sample is being collected, transported, the test should be performed all the way to the clinical action. And here we made a graphic of at least 8 steps. So there are a lot of data for early infant diagnostic, which basically uses the same technology and can be done using the same step of the cascade, where you see that there's a dramatic loss of patients between the moment when the patient comes to the clinic and the sample collection for EID, and then afterward to receive the results. There are a little bit less data for viral load, but as more studies are being conducted, these gaps in the data will be filled. And these are data from several African countries. So when we look at the cascade of care, we realize that there are a lot of system issues that affect the viral load results. And we need to take into consideration the policy and regulation. Do we have enabling policies? Do we have SOP, proper guidance? Are they disseminated? Is there a sample referral system that has enough coverage? What about the quality management system? Are the results reliable? The supply chain, do we have reagent? What happens at the clinic laboratory interface? Are the results coming back on time? And finally, what happens with the workforce that have to take clinical action and also deliver reliable laboratory services? So when we start to fragment the viral load cascade like this, then we realize that many things can happen along the way, and many problems can be identified. And it really goes from the left side of the cascade, where we can have a poor demand from both the patients and the clinician. The healthcare services can be overloaded, and it can go all the way to the lack of guidance of SOPs, issues with sample conservation, shortage of human resources, lack of compliance to guidelines. So there are many issues, and I'm not going to go to all those issues and start to talk about all the intervention that we can make in order to solve them, but I will just highlight a few of them. So the first thing I would like to talk about is the sample referral system that can improve access to centralized viral load testing, and I will show you the example of Uganda. And why I talk about centralized testing is because those machines are already in place, and this is the system that most of the country are using right now. So in Uganda, they decided to divide their laboratory network into spokes at the lower level, whereby samples are being collected to go to hubs, and hubs have a higher capacity for testing and more logistic in place. And finally, those hubs are in charge to bring all the samples to the central laboratory that is doing all this sophisticated testing, and also to bring back the results to the spokes. And you can see on the left a kind of schematical representation of the hubs and spokes, and you can read more from a publication from Fujungo and colleagues in the Clinical Infectious Diseases from 2017. So what happens in Uganda? So they have selected hubs with criteria of capacity, quality management system in place. And they have geolocated all the facilities and the road network 30 to 40 kilometers radius around the hubs. And by doing that, they can place additional capacity in 100 hubs, and they can reach up to 3,000 health facilities remotely. And then they obtain a 90% coverage of their viral load testing capacity. And they have motorbikes rider, and they reach 20 to 30 facilities under their hub catchment area once a week. And at each visit, they pick up a sample and they drop up the results. So this model and these good ideas from Uganda are being now exported to Sierra Leone, and that is done under the leadership of one of my colleagues, Charles Giyaga from ASLM. There's another way to improve access to viral load testing. There's a utilization of point of care to simplify the cascade. What do the point of care do? They actually collapse this cascade into a lot fewer steps, where basically at the facility visit, you condense the sample collection, the test performance, the result return, and the clinical decision into one visit. So there are a lot of point-of-care technology out there, and that reminds me of my first participation to an interest meeting in 2011 in Tanzania, where I had to make a presentation on the technology out there. For CD4, there were a few point-of-care, and for viral load, there were none, which was very frustrating. So I think that we really progressed in that respect. So that figure on the right shows you that for early infant diagnostic, which is basically uses the same technology of the viral load with the point of care, the point of care can improve the percentage of patients that are starting antiretroviral therapy as compared to the baseline, and also the percentage of result return within 60 days. But introducing new point of care technology can be lengthy. There are a lot of barriers to new product uptake. There are unclear regulatory pathways. There's a lack of normative guidance and implementation and how to do it. So countries really, it's difficult for them to select what are the sites where those point of care will be implemented, whether it should be integrated viral load and tuberculosis diagnostic, all these sorts of questions. There's a high price and unclear after-sales support and market entry, and there's a lack of long-term funding, where PEPFAR and the MOH have very little interest to fund unproven intervention and to include this in global fund grants. So what do we do after a product is on the market? There's a lot of effort to have this new technology, but still we need a lot of effort to validate those products and make sure that the results are shared, because a lot of countries continue to validate again and again those products that are already WHO pre-qualified, and also they could use results from a neighboring country. So there's also a need to pilot implementation and put system in place in a very small scale, and then proceed to the scale up with the lessons learned, and demonstrate the clinical impact and have data to advocate for countries and funders in order to invest in those point of care, and also do market intervention to increase access to this new technology. So here I wanted to show you an example of a United project in which ASLM is a partner together with the Clinton Foundation and the UNICEF. And you can see that what you have to do in order to take advantage of this point of care is very diverse. And it's really facilitating the product approval, establishing systems, strengthening the system to support the utilization of point of care, and act on the pricing and look for co-investment. Another area that can facilitate the scale-up of viral load is improving the test result utilization. And why is it important? Because it's very sad, but approximately 50% of CD4 tests and early infant diagnostic tests performed in sub-Saharan Africa have never used. And that is based on the study that's been done by Peter and colleagues in 2017. The figure that you see on the right is a figure that Lara Wojner from WHO shared with us during a regional viral load meeting in Addis Ababa last year. And it really shows that in terms of utilization, the proportion of patients that have a follow-up, a second viral load after they've been identified with viral being unsuppressed is very low. And you have more specific data from Kenya, where only 4% of patients that are unsuppressed have a repeat viral load, and only 1.6 of these occur within 4 months. So what are the problems? I mean, it looks simple. You have to identify the unsuppressed viral load. But I mean, in the reality of the clinical work, it can be complicated. You have to identify this unsuppressed viral load, act on the result, and support patient engagement. And that means that there are 3 things that should be together at the same location: the viral load results, the clinician, and the patient. And that's not always easy to achieve. So there are examples of what works from countries that are supported by donors and that really take the initiative to have this continuous quality improvement within the clinic. And they identify that having viral load focal person and champions that really run around to make sure that these unsuppressed viral load are being followed up is very important. So they need to have SOPs that are specific for unsuppressed viral load, immediate daily review of the viral loads results, registers, stickers on charts having different colors to quickly identify what are the patients that need immediate follow-up, and standardized strategies. And some of these strategies have been collected into flip charts and that are available as toolkits. So having said that, you realize that a lot of these interventions are funded by PEPFAR, which is really the biggest funder for HIV viral loads. And the question is how the other countries that are less funded, that are not PEPFAR funding, can benefit from these best practices that have been identified. And then the other question is, how do you make sure that this improvement that you make to the system in order to have the viral load to work is also going to benefit other diseases? And I think that Dr. Baker yesterday mentioned that it should be possible for all those MSM that are HIV, that are diagnosed with HIV, to also be diagnosed for the other STIs. And finally, how do we bring continuously all those stakeholders in the discussion? So you realize that this problem go way beyond the laboratory. So you have the laboratory nerds that need to be there, the program managers, the clinicians, civil society, policymakers, and the implementing partners. How is it possible? So sharing good ideas and best practices. So how do we do this? Some countries have found better ideas to scale up viral load testing. And how can this innovation, those changing ideas, those solutions be identified, disseminated from one country to the other, and be adopted? So I would like to introduce the laboratory system strengthening community of practice, the LabCOP, which doesn't mean that there's a policeman in the laboratory, but that's an easy acronym for this community of practice. So this is an initiative that is convened by ASLM, funded by Bill and Melinda Gates Foundation, and it is a platform for exchange and discussion between multiple countries and stakeholders for the fast-track identification and dissemination of better ideas in the area of scaling up the viral load. And this is really in the aim of improving patient management. It's not just to have more testing, it's really to improve patient management. And for this project, we collaborate with ICAP and the University of New Mexico. So far, 11 countries have signed on to participate to the LabCOP, and we are very happy that we don't have only PEPFAR countries. The participants are country team, and they have to be multidisciplinary. So what we do is we have interactive online seminar based on the extended community health outcome models that maybe some of you know. And it's completed by individualized country follow-up, either by going to those countries or follow up with phone calls in order to see how we can identify areas of technical assistance. And then the focus areas, the themes that we discuss are prioritized based on the feasibility of behavior change, whether it will interest multidisciplinary audience, and the opportunity for change. So the LabCOP shares recipe as opposed to menus, and it means that those countries are not offered the chocolate cakes on the menu, but they are taught to cook the chocolate cake. So it's not enough to tell, you need to timely identify the unsuppressed viral load. We are going to discuss who is going to be responsible, how you put the stickies on the file of the patient, and really the how to do it. So the first topic of discussion that we conducted in the LabCorp, we talk about the sample referral system and how you can select the hubs, how you can optimize your laboratory capacity for the testing. And we have, at average, 50 to 60 participants to this discussion. So today we had a very vibrant discussion at 2 o'clock about the result utilization, where we had around 60 participants. And I think that this is really a very creative way to share the best practices and accelerate the viral load scale-up and reaching the third 90. So the take-home messages is really that improving access to and utilization of viral load goes way beyond the laboratory. And it should be thought in terms of network. It's not enough to say, oh, I have a nice reference laboratory, I have the machine, my quality management system is in place. What do you do for the network and what do you do for the patient at the national level? The system strengthening interventions are key to the acceleration of viral load scale-up. And this improvement of the system can really benefit other health issues beyond HIV. And many good practices are identified out there, and I hear that every day, how countries are creative, and this needs to be shared and be leveraged. So I would like to stop there, and if you like to take the challenge and mingle more with the laboratory crowd and visit the beautiful city of Abuja, please come and visit us at ASLM 2018. Thank you.
Thank you very much indeed.